Please listen carefully.
Hello and welcome to GasGasGas, your one-stop podcast for the FRCA primary exam. This podcast will fill your brain with information. Listen to it, think about it, and check out the show notes on the website. There you will find the core diagrams you need to be able to draw and describe for the exam. This podcast can squeeze into your day. Listen while you're driving to work, cooking dinner, maybe when you're on call, or in the gym. Eventually the revision is going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Remember to rate and follow the show to hear much more. Hi everyone, this is James at GasGasGas. Today we're talking Thiopentone. Thio, is a classic induction agent, but is perhaps less commonly used nowadays compared to its historic use. It still probably has a niche, and it's something you're going to need to know about for the exams. Some general notes: it's considered to have the fastest onset time of all the induction agents that you might come across. Described as inducing anaesthesia in 1 arm-brain circulation time for a pre-calculated induction dose, which is quicker than propofol, ketamine, and definitely quicker than etomidate, which seems to take forever. Classically, when paired with suxamethonium, you have the quintessential RSI cocktail. This is the classic RSI described as opposed to the modified RSIs that I'm sure you've seen and you've conducted yourselves, with a multitude of other agents in a multitude of other manners delivered. With this RSI cocktail, one of the drawbacks is the paucity of opiate described. So whilst it works real quick, don't look at the blood pressure during laryngoscopy because it's going to be high. Not ideal for a number of patients. Thio itself is a barbiturate. Particularly, it's a sulfur analogue of phenobarbiturate, another barbiturate. Important things to note is it doesn't mix very well with other drugs, so some serious flushing action between syringes is required. It is definitely not friends with most muscle relaxants. By that I mean atracurium, rocuronium, suxamethonium. The only one it might behave slightly well with is mivacurium, that very commonly used paralysing agent. Thio mixed with any of these leads to precipitation. You might block your cannula and you're going to feel pretty stupid about it, especially if you're halfway through an anaesthetic and you can't finish. It is the most lipid-soluble of all the barbiturate agents as well. It has a tendency to hang around, especially in elderly patients, and especially if you've given more than one dose of it. So, moving on, trying to return to a slightly more structured approach for this podcast after we've had our exceedingly long jaunt into the compartments of volatiles, which I enjoyed recording, and it's good knowledge, but we need to get to the bottom of some things. So, with no further ado, Doctor, in a sensible manner, talk me through thiopentone. So thiopentone is a barbiturate-classed induction agent. It is presented as a yellow powder stored in a nitrogen atmosphere with the addition of sodium bicarbonate. It's generally issued in ampules containing 500 milligrams. This is prepared with water for injections, generally with 20 mils, yielding a 25 milligrams per mil, 2.5% concentration syringe. It has a pH of 10.5, very alkali, and it's quite stable once prepared and is considered bacteriostatic at such an alkaline pH. Its mechanism is chiefly at the GABA receptor, increasing the period of time they're open, and it's generally used for induction of general anaesthesia, managing refractory seizure disorders, and as an adjunct to reducing intracranial pressure in those with raised intracranial pressure, i.e. the head injured. Its chief contraindication is in patients with porphyria, where it can precipitate a porphyric crisis. Generally bad news for them. Its dose is 2 to 7 milligrams per kilo, and it gives you about 5 to 15 minutes of general anaesthesia. As an aside here, guys, you've got to think about how much alcohol and other drugs your patient might consume. If they're quite the boozer and they've not had booze in a while, much like with other anaesthetic agents, they're going to wake up quicker because their neurons are inherently more jazzed up at baseline. Routes of administration include intravenous, oral with a significantly prolonged onset time, and rectal. The dose for a rectal induction of anaesthesia would be 1 gram per 22 kilos of body weight, taking about 15 minutes to work. Distribution-wise, it is considered 65 to 85% protein bound. We'll just describe it as 80% protein bound, mostly to albumin. Its pKa is 7.6, so the free fraction is 60% unionized, and its volume of distribution is 1.9 litres per kilo. Of note, it has the property of tautomerism here, so on injection into the blood, the pH change from that quite alkaline pH of the syringe to a more physiological pH leads to the molecule going from more water soluble to less water soluble and less lipid soluble to more lipid soluble in the plasma as it unionizes and undergoes this tautomeric shift into the far more pharmacologically active thiopentone. More on this later. It's metabolized by the liver, undergoing an oxidation reaction which is reasonably slow and is readily saturated, particularly with infusions of thiopentones or multiple doses of thiopentone. Of note, 3 to 10% of thiopentone is broken down into pentobarbiturate, which is another active metabolite, leading to prolonged sedation in perhaps the more elderly population. Also of note from the liver perspective, it's a powerful inducer of enzymes. The plasma redistribution half-life is around 8 minutes, and the clearance half-life is 3 to 22 hours or so. The body achieves 2.7 to 4.1 mils per kilo per minute clearance. So not bad, not great. If you think about all these features, guys, the zero-order kinetics, the high lipophilicity, the perhaps slow real clearance out of the body, you can make an assumption that the context-sensitive half-time of this drug is going to be quite long if you happen to infuse it. Of note, infusing thiopentone is quite a rare event, reserved mostly on intensive care units for refractory status epilepticus, where you just need to turn the brain off for a period of time and hope that all those glutamic excitotoxic molecules calm down and then everything settles. Or if someone's got rip-roaring intracranial pressure as a last-ditch attempt to lower it. Anyway, back to telling you all about thio. Side effects. So there's a range of side effects with thiopentone. Cardiovascular side effects. There's a dose-dependent reduction in cardiac output, stroke volume, and systemic vascular resistance. You can also consider that this might be exacerbated in hypovolemic patients and acidotic patients due to the increased fraction of available thiopentone. On paper, it probably yields less of a blood pressure drop versus propofol at similar anaesthetic doses, and it's noted to be a venodilator as well. Respiratory effects. It is a respiratory depressant, and actually on that initial dose of induction thiopentone, you might render the patient apneic. Contrary to that though, the odds are that you've increased the reflexivity of the larynx and airways, so trying to cite an eye gel as an emergency in a thio-sucks RSI when you can't intubate, you might find yourself struggling as that sucks wears off and their upper airways are quite ticklish. Less of a problem if you're using rocuronium though. CNS effects. So naturally, it's a smooth and rapid inducer of anaesthesia. It is an anticonvulsant. Its other useful features are that cerebral blood flow, intracranial pressure and intraocular pressure, your eyeball pressure, all decrease, and it leads to a reduction in the metabolic requirements for oxygen of those neurons. So if you're in a marginal state where you don't think you're getting much oxygen to many neurons due to bleeding, head trauma, injury, etc., you could reach for the thiopentone to reduce the oxygen demand. Other induction agents also have this effect, except for maybe ketamine, depending on who you ask. The other chief relevant side effect is the influence it has on your urine output. So you get decreased renal plasma flow, perhaps secondary to the cardiovascular effects, but also an increased secretion of antidiuretic hormone, leading to the body being more driven to hold on to free water in the collecting ducts of your kidneys. Of note for obstetric anaesthesia is it does cross the placenta, so you might end up with an anaesthetised baby as it comes out. Some units still have thiopentone drawn up as the emergency agent of choice. That prescriptive nature is shifting away, and propofol is also a recognised option in this patient cohort. I suppose the advantage of the thio being left on the side all day is that it's bacteriostatic and actually lasts for quite a long time once drawn up and is very stable, whereas having a 20ml syringe of propofol drawn up, sat on the side all day, might raise a few eyebrows. Toxic considerations: 1 in 20,000 chance of an anaphylactoid reaction. If you cause a large quantity of it to extravasate because you're using a dodgy cannula, you're probably going to cause tissue necrosis. And if you accidentally put it in someone's artery, you're going to trigger spasm and thrombosis and limb ischemia because it's going to precipitate once it gets to the capillaries and the pH shifts. So beware desperate cannulas cited in ACFs in A&E, especially if you're reaching for the thio, if you've got a patient who's just seizing away. Tricksy. Right, so I mentioned a couple of concepts there. We're going to pick out a couple of them just to go over in a bit more detail. So I've mentioned zero-order kinetics. This describes a enzyme-related clearance situation whereby you find yourself with a fixed clearance rate of drug per unit time. Think 10 milligrams cleared an hour every hour. A good example of this is actually alcohol, and that's why you think about alcohol in units. A unit of alcohol takes 1 hour for a standard human to clear because the enzymes involved in clearing alcohol get rapidly saturated. You can therefore imagine that if you were to have many doses of a drug that rapidly saturates an enzyme clearance system, it'll hang around for a really long time. Thinking about zero-order kinetics in another layer of detail, just think about this system as a product, substrate, enzyme situation and compare it with a graph in your mind of what first-order kinetics looks like. First-order kinetics would be where you have a situation with untold quantities of enzyme, all pretty keen to get going. It is important to note that enzymes have different rates of activity, so you could have 10,000 very busy enzymes or 10,000 pretty lazy enzymes. You can imagine that the lazy enzyme situation is going to saturate more quickly if you provide it too much product. But below that saturation point, the curve of clearance is non-linear and is actually probably a bit more logarithmic looking. We'll go into more detail on this when we do Michaelis-Menten kinetics. There's the nuance of not just the quantity of enzyme, but how speedy that enzyme is. To tie this in, if you have an enzyme system readily saturatable, your drug infusion or drug dosing situation might be more susceptible to prolonged context-sensitive half-times. We mentioned this situation with fentanyl, whereby it's so lipophilic that eventually you fill the patient, much like you eventually fill the patient with sevoflurane. Examples of enzyme systems that are very tricky to saturate would be the plasma esterase system, which is blisteringly fast and quite good at clearing remifentanil. This is reliant on the potency of remifentanil as well. If you imagined that remifentanil might be 1/10 as potent and you have to use more drug than we classically use, it could end up with a situation where we were to saturate that enzyme system. Another example of a very efficient enzyme system that isn't terribly drug related is carbonic anhydrase activity in the red blood cell. And this is probably one of the fastest enzyme systems in the body, doing a very particular task of converting your CO2 H2O situation to carbonic acid and back in order to squirrel away carbon dioxide in your red blood cells. The next concept I've alluded to is bound fractions. So we've noted that thiopentone is 80% protein bound and is 60% unionized at physiological pH because of its pKa of 7.6. It's important to note though that the unbound active fraction is the part of it, the component of that dose that isn't bound to the protein. So if you give 100 milligrams, and 80% of it ends up protein bound, then you're working with 20 milligrams of free drug, and so actually you've only got 60% of that 20 milligrams floating around being active. Yet that relatively small fraction yields anesthesia in one-arm brain circulation. Therefore, it would lead you to think that a patient who was terribly acidotic or actually had nephrotic syndrome and didn't have very much protein in their plasma, you gave them the standard induction dose of thiopentone and you'd probably end up in tiger territory with loads of unbound drug causing untold havoc on your cardiovascular system. I think thio is a great way to illustrate that risk, and it's something to think about with other induction agents as well, considering their protein-bound availability and what may or may not displace them. For thio, ibuprofen can displace it from albumin. The last thing to mention here for thio is tautomerism, Tautomerism. And this is a type of structural isomerism. You need to go read about isomers, and we're going to talk about them at some point. What occurs in this situation is when it is made up with your water for injections in your syringe, it's quite an alkaline environment, and that environment influences the sodium thiopental to remain in its keto form. It's nice and water soluble, which is what you want. However, once you put it inside the patient, the pH drops naturally to physiological pH, and it unionizes. It then subsequently drops the hydrogen from its sulfur molecule, leading to a conformational change in the thio that makes it much more lipid soluble. If this was the case in your syringe, then it would be quite hard to mix and draw up and deliver, wouldn't it? Because there's not much lipid in water, and you'd have to try and mix it with, I don't know, soybean oil or something. I'm sure they don't. So that's why you need to think about this. The other molecule in anaesthesia that we often tout as being tautomeric is midazolam, and we'll talk about that in a future podcast. So when is actually really thio used clinically? From an educational perspective, the first RSI I did was with alfentanil, thio and sucks, so it was a modified RSI. It works very quickly, but it is a bit of a faff to draw up. If you've not paralysed your patient because you've tested if you can ventilate them before you do, another modified RSI technique, and you think, oh, I can't, what are you going to do? You're going to paralyse them then, when you've already been a bit cagey, or are you going to stick an eye gel in? Patient probably won't tolerate the eye gel very well because it's thio and you've not used propofol. I would generally be tempted to use it in an adult with refractory status, although more commonly I would just reach for propofol and perhaps think about thiopentone on ITU later when that paralysis wears off and actually the patient's still seizing away. If that's the case, despite your propofol infusion, then it's probably quite bad news for that patient. A historical note with thiopentone, and people might bring this up when they're talking about thio, is the story of soldiers in Pearl Harbor. Rumours exist that actually there was quite heavy-handed use of thiopentone and people weren't waking up afterwards and they presumed they were brain injured, brain dead, and they'd turn them off. Looking at a few articles and some analysis of what was published after the war, because clearly during a war you're not going to publish to your people how many people were truly killed when an attack happens because it looks bad. It probably transpires that there were some unexpected deaths due to thiopentone use, but that they were using either 5% or 10% concentrations of thio and giving quite a lot, describing a situation where they would administer the drug and then describe a situation where the patient turned very mottled and died. Later, in another letter or article to the editor, a physician describes using 400 milligrams of thiopentone over 1.5 hours, whilst also administering nitrous and oxygen for a severely shocked patient who'd had a gunshot wound, administering 2.5% thiopentone in small doses. And that's like an induction dose of anaesthesia in an adult, 400 milligrams over 1.5 hours. Nitrous is good, but it's not sparkling. But then closes the article by saying 3 weeks later, when the patient needed a trip back to theatre for some other sorting out, the patient chewed through 400 milligrams of thiopentone in 10 minutes. This really probably demonstrates that the fact that this bloke was probably very acidotic perioperatively, had quite a good free fraction of thio, and that maybe there was some enzyme induction that had happened for that second case. Who knows? Anyway, getting carried away talking about thiopentone is a good drug, but there are better drugs now. If you found it useful or awful, please like and subscribe and rate the show. Definitely check out the show notes for those diagrams and the detail of this content. It is a bucket of content to get to grips with. Keep working at it, and you will get better, faster, and stronger. It is vital to keep your interest live for the science that we're covering and not overcook yourself. You will be amazed by what you know come exam day. Don't freak out. Keep studying.